the results of the midterm go pretty much in line with how you're doing with your quizzes overall. So it's a pretty good indicator of where you were going to be, unless you do something drastically different, of course. All right, let me start. Not do. Okay, so today we are going to talk about dilated cardiomyopathy, this first section. It's actually a shorter set of slides, so it may not take us super long to get through today. Recording. Okay, here we go. So dilated cardiomyopathy. So the idea here is that, hang on, I'm not seeing your guys' awesome faces. Just a second. I should be seeing you. Oh, I can share screen. That's why. There we go. Now I see your face. So dilated cardiomyopathy comes down to just the chambers being dilated. Again, primarily we talk about the left heart being dilated, but again, as we progress in the field, we're starting to do more and more research on the right heart also. So you're going to see more and more of that information coming out as well. So here, just up the first part to show you well, that shows a normal heart. Honestly, that's a pretty thick-walled heart in that normal picture of the pathology. That looks like it's probably hypertrophic cardiomyopathy, as opposed to the dilated cardiomyopathy, which is quite dilated. The other thing to kind of point out here is as you're doing your echo, and as you can imagine doing your echo, and we think we're seeing those interior walls of the endocardium, notice how much trabeculation there is in that left heart in this dilated sample that we're seeing. So what we want to see is the blood pool coming into here, even though there's some of these muscles coming out. I'd say this is more than the average person has. This seems to be fairly trabeculated. It might be a little bit closer to the apex, and that might be why. Considering this is dilated, this shot here may be right close to the apex, but this to me still seems like it's quite thick from what it should be. Just FYI, but we're looking at big dilated chambers. So good rule of thumb again in echo is when you see things really well in the heart and you're seeing things, you should suspect that something might be wrong. If you see things super well, it's either going to be a really good, easy patient to scan, like Tyler, for example, or you're seeing things because there's more fluid than should normally be there. And if that's the case, then you might be seeing things a little bit too well, and you should be suspicious of something going on. So anytime you see things well, be cautious. This slide to advance here. There we go. So definition, it's characterized by bilateral and biventricular dilation and ventricular systolic and diastolic dysfunction with an unknown origin. So in other words, basically we got a big dilated heart. It's usually going to affect both sides of the heart, and it is independent. So if it's a true dilated cardiomyopathy as a fundamental cause, it's independent of other things happening. So something didn't necessarily cause it, like an aortic stenosis, for example. It's valves are working fine to maybe mildly problematic, but the heart itself, the muscle itself, is dilated for some other unknown reason. So there's not, in other words, there's not any super obvious reason that it should be dilated. Diseases that are intrinsic to the myocardium is what we're looking for a true dilated cardiomyopathy issue. Can it be dilated with other things? Yes. I mean, we could have a huge MR. It could be causing it, a huge AI, stuff like that could cause the heart to dilate, et cetera. But it's kind of a concentric, bilateral thing, and the valves seem to be in pretty decent working condition. Having said that, as it becomes more and more dilated, you are going to start to develop significant MR because it's stretching the annulus of the mitral valve. So the question is really, was it the chicken or the egg? Which came first? Kind of what we want to try to go down the path of doing. But if we don't see any other obvious cause of something going on, it might be just dilated cardiomyopathy, which is an inherent muscle and myocardial issue. Okay, etiology here is idiopathic. So it can have a familial transmission in 10% of cases. So in other words, it's genetically passed down. Okay. You could have things like alcohol abuse can cause it, viral infections, myocarditis. So with viral infections, that could be including COVID. So this might be one thing that you see with a COVID presentation. And so it's good to point that out, because as we are currently still in the pandemic, then you guys are going to be out scanning in the clinical site soon. You might see this as part of the presentation. Could be postpartum cardiomyopathy. So again, after birth or even just pre-birth could cause that to dilate because of that extra fluid volume that we have to push through the baby as well. Chemotherapy agents. So we do strain imaging quite often with chemotherapy patients. That is the most common use of strain currently, but there are, again, many other uses. But as they give them chemotherapy, you're going to notice that the hearts are starting to get dilated cardiomyopathy. We had a student one year that as a child, they actually had chemotherapy because of the childhood cancer that they had. And that person's heart was actually fairly dilated. It was kind of, round and balloon shaped. It wasn't that nice bullet shaped LV that we normally see. But again, no surprise to what we saw, because that goes along with the diagnosis. They could have systemic hypertension, long standing, so many years of high blood pressure that just, we got the afterload that it's pushing against, and the heart eventually just kind of stretches out, and at some degree will actually start to give up in essence, and you might have a lower ejection fraction. Sarcoidosis is a infiltrative type of disease process that can cause it. Toxins like medications or illicit drugs like cocaine. X-linked familial cardiomyopathy. So again, it could be a genetic cause. There could be endocrine disease, so either hypo or hyperthyroidism. Coronary artery disease can cause it. So again, if we have heart attacks and stuff like that and weaken the walls, then that could present that way. And acquired immunodeficiency syndrome, such as AIDS, but also any other really autoimmune type of disorders is what that's going to go along with. So it's not that there isn't a cause to those things, it's just going to be a little bit more general than what we can diagnose in the echocardiogram itself. We're just going to prove the chamber sizes, we're going to prove what's going on with the heart, and then the doctor, the cardiologist, is going to take the rest of the patient's clinical information and put it together to determine what exactly is going on. All right, related etiology then. You could have CHF, congestive heart failure. You could have chest pain. We might have fatigue and weakness. This patient might have dry nocturnal cough. So they'll have a dry cough at night, particularly when they're laying down. They might have palpitations like AFib or ventricular tachycardia. Hopefully it's not VTach, but that could be. Hemoptysis, what is that again?
The breaking up of blood cells.
Okay, so the blood cells, so hemoptysis means that they're coughing it up. So they'll be coughing up blood. What other disease process did we talk about already that they might have hemoptysis as well?
Aortic stenosis?
Mitral stenosis?
Mitral stenosis, yes. Good. I mean, I guess in severe cases they could with aortic, but it's more likely in mitral stenosis, and then this is the other one. So why do you think a dilated cardiomyopathy may contribute to hemoptysis? Think about
The
it.
lung is going to be overwhelmed with fluid again, like through the mitral stenosis. So
yeah, so it's
same mechanism.
buildup of fluid leads to a buildup of pressure. And that buildup of pressure, once the pressure exceeds a certain amount, that's really when you start getting blood leaking into the alveolar beds and being coughed up. They could have syncope, lightheadedness, and sudden death, likely due to arrhythmias. Okay. So again, just the generalized concept of if we stretch a chamber out, we know that we've got those special conductive cells, our tracts that conduct a normal beat. But remember, we can also irritate the cells themselves, and if we irritate the cells themselves, they can initiate a rhythm abnormality. They can initiate an electrical signal. And so anytime that we stretch those chambers out significantly, it's going to affect those cells, which may cause irritation, which may cause these arrhythmias to occur. And it could be any number of arrhythmias from the atrial to the ventricular. Obviously, VTAC is our more concerning ones, VTAC and VFib. Those are the ones that would be detected to use, we would indicate usage of an AED and recommending a shock. All right, on the physical exam, you might have evidence of left or right heart failure. Okay, so what do you think would be evidence of right or left heart failure? So we're dilated. What would tell you that that dilated heart is in heart failure?
Like systolic dysfunction and diastolic dysfunction?
Yes, both, yes. So as we start to progress in this, and this is why, like I say, systolic function and diastolic function are really the bread and butter of echo, is every major anomaly that happens comes back to those two things, and really the viability or the strength of the heart is indicated by those two types of function. And that would eventually affect both. If we're seeing systolic function, we already know that we are likely already having diastolic function as well. So things like people on chemotherapy, for example, one of the reasons they use strain imaging is because it's an early indicator of diastolic functioning happening before you even start to see it actually happening. I was talking to Tammy yesterday, and they were talking about a kid that was in the pediatric unit that they've been working with, and they used the strain imaging, and she said that with strain imaging, it's not like your the auto recognition of the auto EF or things like that, where the system does the ejection fraction for you, which by the way is a thing. And by the way, our Sequoia does it, but I want you to still do it yourself. That's sort of done off of pattern recognition, looking at the actual tissue, and it's actually going into the system, and it's going off of a database of thousands of real cases that have been measured, and comparing those to what the system sees on your image, and then making the best extrapolation of that, and then you can adjust it, and that's how your auto EF works. Every vendor is a little bit different. That's how Siemens does it. Other vendors do it off of just recognizing border detection. Similar ideas and stuff, just a little different way of attacking it. The strain imaging, however, it actually sees things that you don't see. So as long as you have your system optimized pretty decently, the system will detect, the strain imaging package detects things that you actually can't visually see with your eye necessarily. So it determines the real signal to noise ratio without the effects of gain and stuff like that getting in the way. And what she said was that the doctors tell them not to try to tweak the results of it, because what they've found and what she has personally found is that as she uses the strain imaging, they'll start to show things that are abnormal, and a lot of techs will try to make that fit the normal pattern and kind of adjust it so that it tells them what they want it to tell them. But that's a technology that you really need to trust. Provided you've got a decent image, you want to trust that system, because what Tammy said that she's found is that when she finds that the strain imaging starts to show some dysfunction going on, and all of your other measurements and parameters don't show anything going on, so you want to make it normal, what she finds is that over time, whether it's weeks, days, or months, that patient starts to develop those actual problems. So strain imaging is a way to really, really early on detect what's going on without the bias of your eyes, okay, which is kind of nice. So you kind of want to trust your strain imaging package. Okay. So these patients might also have a lower blood pressure. The low blood pressure is going to be likely because your ejection fraction stuff is suboptimal. It's not because there's not a backup of pressure, because there certainly could be, but now you're starting to get into congestive heart failure, and the heart's starting to give up. It's not pushing out the systolic beats like it once was. Narrow pulse pressures may result. Pulsus alterans, that's alternating pulses, strong and weak, strong and weak. Peripheral cyanosis. So I don't think we've talked a lot about cyanosis. What is cyanosis?
It's the bluing.
Yes. So it's bluing of the lips and fingertips and stuff like that. If you're not wearing nail polish and somebody's cyanotic, you can actually see the blue on the fingernails. You can see it around the lips. You can see it even around the eyes of the patient. So cyanosis indicates a bluing or gray color, and that indicates that there's a lack of oxygen. That's also something that you see with right side dominant pressures. So if we've got an ASD, for example, and the right-sided pressures are higher than the left, and it's pushing from right to left, your patient will look cyanotic. They will be very sick, and they will look kind of a bluish gray color. Even their entire skin, they'll look extremely bluish gray. But the ones that you can notice first are going to be the fingertips, under the fingernails, and the lips and eyes, around those areas first. Tachypnea. So again, it's not a tachycardic, but a tachyrespiratory, so to speak, a fast breathing rate. And again, that makes sense because if we got a lower ejection fraction, the brain's not getting the oxygen that it needs to have, and therefore it starts picking up the pace, and they start breathing faster, trying to compensate for that. You'll likely also have the heart may start beating faster as well, even though it's weak. And again, keeping in mind that these are, if you're having all these types of symptoms, you're having a very, very severe case. Okay, when it's mild dilated cardiomyopathy, we're not quite at that stage. And of course, it would be exacerbated by exercise. So if I was to, go run, and I was in a situation where we've got dilated cardiomyopathy, then running may exacerbate that, and then they may start exhibiting these types of symptoms, particularly like the cyanosis and the shortness of breath. They'll have a diffuse apical beat that will be displaced inferolaterally and diminished in force. Okay, so again, it's just kind of displaced. We now have if you were to do an X-ray of a dilated cardiomyopathy patient, this is where they do like a chest X-ray when somebody comes into the ER, and they find that the cardiac silhouette, or the outline of the heart in the X-ray, is larger than it should be. Okay, there's a couple reasons that could occur. This is one of those reasons. It's dilated cardiomyopathy. The other one is a hypertrophic cardiomyopathy. That means that the heart's big. This one's just big because of lots of fluid. They could have non-sustained right ventricular apical impulse located along the left lower sternal border. Okay, those aren't details I'm necessarily going hog wild after, but just the FYI. They could end up in AFib. Again, any electrical abnormalities would present themselves, AFib being one of the ones that we would see commonly in an echo lab. Cool, clammy skin is going to go along with that peripheral cyanosis. Small volume carotid upstroke. So if you're palpating the carotid pulses, it might be a little bit weak. Left lower parasternal lift indicates right ventricular dilation. And again, that's just them palpating on the chest and stuff, the heart. Okay, so what complications do we have? Again, anytime that we have a slowdown of fluid, we're going to have issues. So without going into too much of this, in fact, I'm going to jump back a slide. What do you think might happen? So we have a dilated cardiomyopathy. Again, the fundamental issue is that the muscle itself is weak and the chambers are dilated. It's not pushing the blood out very well. That means less motion, less, higher pressure, stuff like that. So what do you think you would see on an echo? Let's just discuss that before we go into it. What do you think you might see? What complications might you have?
Just like the walls, like not squeezing as much.
Okay. So definitely we're going to see ejection fraction issues. Other things?
Also, like thrombus formation.
Thrombus formation for sure. So again, if we have a low ejection fraction, now where do you think the thrombus might form if you're just thinking about it?
In the trabeculations.
Okay, so yeah, it could happen in the ventricle itself. Again, if we got a low ejection fraction, particularly near the apex, if we're not getting a good squeeze and not pushing that blood, that certainly can happen there. Where else might it form?
Like wherever there's like a wall abnormality, maybe.
Okay, if there's a wall abnormality, yes. What about other chambers?
Wouldn't you see it in the appendages also?
Yes.
Because the blood flow isn't going through?
Yeah, particularly the left atrial appendage. And we talked about the right atria. The place that was most likely to get there was the right atrial free wall and those pectinate muscles. Okay, so anywhere where it can attach, it will. Just thinking of the heart and the shape of the heart that it is, keep in mind that a dilated cardiomyopathy now, it's not the normal shape anymore. It's kind of a balloon shape. So you've all seen a balloon as it's blown up, gets dilated. That means that the fluid's not getting around. So it's going to be at those peripheral edges, those areas where blood kind of doesn't flow well. In the middle of the chamber and close to the valves, you're probably not going to see a lot of thrombosing, but in those pockets of spaces and stuff everywhere, that's where it's likely to stagnate and form clots. So good. All right, and because of the electrical abnormalities, you might have sudden cardiac death, or basically it induces a heart attack. They call it sudden cardiac death because it's cardiac cause, and these patients often do die when it gets to that stage. Again, I kind of heard, I believe this was from, I can't even remember who it was from. I think it was a cardiologist at one point years ago when I was scanning, suggested that, and I don't have documentation to prove it, but they suggested that once people get into congestive heart failure, meaning that the EF and stuff is reducing because of all this dilated cardiomyopathy issue, it really is a terminal diagnosis, even though it takes sometimes years to occur. It might take about 6 or 7 years to, for that patient to ultimately expire, which is the medical definition, by the way, of death. It can take some time, but once they start hitting this stage of the heart kind of giving up on itself, that is a terminal diagnosis, really. And if you scan that way, they might be able to have some corrective things to help boost things back. Just know that they're going to be following that patient out, just make sure things don't go back. It's sort of like a patient that has cancer removed. They can go into remission for a while and often it comes back. So we want to just kind of watch that. You could have infective endocarditis may occur. Now, again, the infective part suggests that there's an infection or a bacteria or fungus that seeds itself into the bloodstream and onto the heart itself. This is more rare because you still have to have something that gets a bacteria or fungus into the heart to do that. However, as we mentioned, that you could have this in patients with autoimmune type of disorders. They can have a non-infective endocarditis that's not an infectious process, but they can still develop vegetation. And again, we'll talk about vegetation in a different chapter coming up. So that one's a little bit more rare. Okay. And there's just, again, a diagram just showing relative chamber sizes. The normal heart there shows the right ventricular apex going out a ways. I'd say that that's probably a little bit less accurate of a representation. Usually if we're looking at an apical 4-chamber view, the right ventricular apex typically does not go as far out as the left ventricular apex does. So I'd say that diagram's a little bit off that way. But generally speaking, yes, you see the chambers start to expand in size. They become more rounded where it was more pointy before. And again, what we worry about there is annular stretching on the mitral valve in particular, causing more leaks, which just exacerbates the problem. You kick into that sort of positive feedback cycle that, you know, things continually get worse and worse and worse until the heart ultimately gives up. That's why we intervene. That's why we treat with medications. That's why we might do procedures to help change that. We may even do cardiac pacing with a pacemaker to get the heart to start to build up its strength again and remodel in a positive way to try to get that shape and function back. Okay, auscultations. Again, I'm not going into super details on the auscultations for our purposes. So again, just to quickly review the auscultations. So we hear S1 and S2. Just give me a brief synopsis of what those are again. What is S1?
All the
Diastolic, open the mitral.
Okay,
closure.
so
S1 is, yeah.
this is the atrioventricular valve, so it's mitral and tricuspid. And usually, again, we hear them right close together, so we hear it as one sound. Remember, splitting is when you start to hear the distinct valves from each other. So a splitting of that would be hearing the mitral valve and tricuspid valve separately. S2 is what?
So semilunar valves.
Okay, semilunar valve, good. So, and again, with that is if we split out the sound, that means that there's something going on. It's usually a pressure issue that's causing one to close sooner than the other, from left to right side heart issues. And then we distinguish the S2 as like a P2 or an A2 instead. Okay, and then you have these other heart sounds kind of come out. So just a note, so the soft S1, so S1 again is an atrioventricular valve, it's soft. Why do you think that sound is soft again from what we talked about physiologically?
Is it because the left ventricle is stretched or wide and it's not, the pressure isn't there to snap it closed?
Yeah, the pressure is there, but what do we know what happens when we stretch that out significantly, like you say? What other pathology do we develop because of that?
Regurgitation.
Big time regurgitation. And so what is the sound, what does the heart sound come from?
The valves shutting.
Okay, so that's the shutting of the valve. So you're hearing them slap together. If we're getting a leak, that means at least some portions of that valve aren't touching. So that's why it's soft, is because now we have less of that, less coaptation area. Zona coapta is what it's called, where it's actually touching each other. So it's going to be a softer sound, and we've got bigger fluid volumes. So the fluid volume is going to dampen the sound as well from getting to where it's coming from to your ear at the chest wall. So there's kind of a couple things that contribute to that, but it will be a softer S1. So the S2 is paradoxically split. So what does paradoxical mean again?
Like opposite of the norm.
Yeah, so opposite of what you would expect, right? So it's just going to split, and that's in particular with a left bundle branch block that may develop. A narrowly split S2 is going to be an indication of pulmonary hypertension. So if we get super high pressures in the pulmonary side, it's likely to close before the aortic valve does. So you're actually going to hear the P2 before the A2. And again, if you're trying to distinguish that, now we as an echo tech don't really do this with the auscultation. This is the doctor or the provider. Again, because the pulmonary is shooting out towards your left side, okay, it shoots out that way and then it bifurcates off, but that's the direction that the valve is pointing. If we're listening from this side, you're going to hear that louder if it's pulmonary. You hear it on the right sternal border if it's aortic, because our aortic is shooting out that direction. So whichever one you're closest to is the one you're going to hear the loudest. Nancy, go ahead.
Regarding to these auscultations and hard sounds, and our job is probably rarely using a stethoscope on our patients.
True.
Is it on the registry?
There may be some stuff on the registry, yes. So knowing what splitting is, the paradoxical split, some of that, and there are documents, should be in the resources, and in the 263 class, I usually give a couple more sources to look at. One, if you really want to understand heart sounds and have the time to do it, one of my favorite YouTube videos, it's called Dr. Najeeb. That's Najeeb. He's got amazing videos, and honestly, he spends an hour just talking about heart sounds 3 and 4.
Right. I understand that. And I understand that it's great for people who need to know it. And it's a great resource for them to need to know. But really,
yes,
do I need to know this?
I would say there's likely to be 2 or 3 questions on the exam.
Okay.
So it's not irrelevant, but if you've got the extra time and you got you're bored and don't know what else to go back to, then I would certainly tap into a little bit more. I do think it's a value to understand what's going on. I think you'll understand better what goes on as an echo tech and be better at diagnosing. And I would practice. It's I know a lot of labs, the echo techs don't use the stethoscope. I would highly recommend it because if you're working with the cardiologist, you know that these patients have this. It's an extra step that we can do that's not terribly invasive to the patient, that you can listen to it and maybe get some insight as to what's going on.
Right, but I understand that time is also very, they're like, push patients in so you can do 8 to 10 echoes a day. You don't have time to auscultate.
Well, it depends. Once you get good at scanning, you will have time. One of my students down in Boise, he's actually was commenting the other day that he's down to 30 minutes of scanning. So that's actually pretty good. And, I would say that you could do a good echo tech's going to be between 20 and 30 minutes on pretty normal studies. They might take a little bit longer with an abnormal study. But yeah, our time will certainly get down to there. And most labs schedule their patients for an hour. So you actually do have a fair amount of time. So once you get good at scanning, yes, you'll have more time to do that. And do it in conjunction with your doctor. I mean, they've got some, they can teach you, and they love to teach techs, the different things like this.
Hey, Scott, would we ever receive physician indications with auscultations?
You might, yes. So, I mean, it might be as simple as a murmur, okay? All these auscultations, they can be murmurs. They can be other things. They might actually indicate what the murmur was as far as the sounds. So they could say that, which could indicate. So we know that S1 and S2 are normal heart sounds, so you're probably not going to get a paid for study based off that, unless they said that there's a splitting, or they have a paradoxical split, or a louder or a soft sound. Could be an indication that something is going on that would justify paying for an echo. Heart sounds 3, 4, these summation gallops. There's like 8 different heart sounds, maybe even more, that could be indications pathologically of something going on that would justify doing an echo. Okay. Irina, did you have a question too or a comment? I saw your hand go up, but it's okay. Good. All right, so murmur of the mitral, tricuspid, and/or pulmonic regurgitations could occur. So they could be hearing those low rumbles. They could be hearing from those different locations. So they might have some suspicions there. And again, those are going back to murmurs. All right, so how do they treat it? So if they know what is causing it, then they can treat that specifically. If it's generalized, it's probably going to be just more diuretics and things like that to try to control things overall if they don't really understand what's going on. They might have a reduction in activity or prolonged bed rest. And again, these are severe cases. So the more mild cases may not have such a radical use of treatment. Almost always they'll probably have some oxygen treatment just because of the shortness of breath issue that it introduces. They might have some dietary modifications that, you know, especially if they can catch this early on, sort of like diabetes and things like that. If we can catch it early and people can control it over their lifetime and take care of themselves better, these things aren't going to become problematic as fast. Okay, again, it doesn't mean that the issue's gone. It just means that they can tolerate it more. Avoidance of alcohol. So alcohol decreases the ejection fraction. I know that people always, you know, so I'm not a drinker, so I don't know, but I know that it is a depressant, and most people feel like it's the party thing to drink, right? So they often get funny, they do weird things, they have their inhibitions or decreased, but alcohol itself is a depressant, okay? And on the heart, it will decrease the ejection fraction. So, you know, somebody that goes into alcohol poisoning and stuff like that, they could have a very low ejection fraction. Their heart might be getting hit pretty significantly. Again, diuretics and digitalis and ACE inhibitors, beta blockers, all those medications are things that they would control to control both the preload and the afterload. Because if the EF is affected and our heart is becoming weaker, it can't tolerate a whole lot. So we don't want to overstimulate the heart. And, you know, so in addition to that reduction in activity, these medications are going to help to reduce the stress on the heart with the volume load and pressures. Anticoagulation if there's a strong suggestion of blood clotting going on, or we're concerned about that. Antiarrhythmetics if we're getting EKG abnormalities coming out. Again, they might need to use a pacemaker to help to rebuild the strength of the chamber. So that's where the dual pacing might be part of it. And if they really need to, they'll have an implantable defibrillator. So that's where they'll have that big box underneath the skin, typically on the left side, and then those lead down into the heart directly. All right. And a funny little comic there. So each capsule contains your medications plus treatments for its side effects. I think that's kind of funny because I used to be a farm tech, and yeah, there's, you know, you take one medication and you almost need another 2 medications to counteract the effects of that one medication. And it's just, it's a, in its sense, a positive feedback cycle for that as well. It seems like the more you take, you start taking medications, you end up taking more and more medications to counteract the effects of that medication. And everything just sort of adds on itself. That's why me personally, I do whatever I can to not have to take medications, because once you start down that path, I've just seen too many patients that, you know, cardiac patients in particular, they'll come out with just stacks of bottles that they have to take daily, usually multiple times a day. So kind of funny because they've got that great big horse pill that's massive. It'd kind of be nice if they put it all in one pill, actually. All right, if they need to do surgery, so obviously the last stage that we're going to try to treat with is surgery. So they might have to do valvuloplasty replacement. So either repairing the valve itself and or replacing the valve with either mechanical or bioprosthetic. Again, those are because of the regurgitation that's caused by it. The Batista procedure is a ventricular reduction. So they actually go in, they can cut out part of the wall and kind of sew it back together, kind of gathering it together so that we don't have that big balloony shaped heart, and we can kind of restructure that. Transmyocardial revascularization. So they've got the percutaneous or surgical, just revascularizing. Left ventricular assist device, those LVADs. As you can see in the picture there, so that just kind of shows what it is. Again, it's a little, let me the pointer here. So they've got out of the, so this goes right into the left ventricle. You'll actually see it go inside the ventricle when you're scanning. It's a big tube that comes in at the apex, comes down. Here's your little device, powered by battery and stuff like that, and then it pushes it up and it bypasses it by jumping past the aortic valve into the aorta and bypasses it so that the, you know, this is last case scenario. This is the patient's heart is essentially giving up, and this is buying them time to either do a procedure or do a heart replacement. They could do cardiac myoplasty. So again, it's taking segments and stuff and cutting the muscle, repairing it. Or they could do cardiac transplantation, which would be your last measure. So it's putting a new heart in. Obviously, there's not a whole lot of those to go around, so that's not a good option. The last option. All right. So echo. So again, let's stop here for a second and just have a bit of a discussion. So what do you think you would want to look at with an echocardiogram? If you were to go in and you knew the patient had possible dilated cardiomyopathy, what do you want to show me? Size. So that means we got to see the chambers. Good. So is it visual enough, or do we need to show something else?
Ejection fraction from your biplane.
Okay. So ejection fraction is going to do two things. It's going to show us the volume, but it's also going to show us the ejection fraction. So it's comparing the systole and diastole, but that both of those are important in this case. Good. So Simpson's biplane, we definitely want to do that from a couple different planes. Good. What other measurements could we do?
Wall thickness and inner diameter.
Okay, good, good. Yes.
I have some confusion. So is all dilated cardiomyopathy not related to coronary artery disease? And like, how do echo techs determine if it's not related to coronary artery disease if they have exercise intolerance? Like, what if we can't stress them?
It looks like the ischemic, if there's ischemia, then there's systolic dysfunction. It's greater if there's ischemia. Then you'll have reduced systolic function.
Right.
That's what I just read.
Yeah, so it's true. You will have the reduced systolic function. The other distinguishing factor, I guess, between that is both cases you are going to probably have some dilation and shaping differences. In a dilated cardiomyopathy situation, it can be caused from CAD, but that's when it's more global and you can't tell for sure that it's CAD. We know with CAD that if you see regional segments that are out, that's diagnostic of CAD, even though both have dilated cardiomyopathy. So yes, I mean, it can be part of that, and that's why it was listed in there, is because it could be a global thing, and we don't know for sure that that's what it is. So as an echo tech, our job to distinguish it there is finding those regional segments, seeing if there's scarring, aneurysms, things like that, that would indicate that it could be CAD instead. But generally speaking, yes, we're going to do the measurements. We're going to look for chamber size, anything that shows chamber size. We're going to measure it in any way we can. So our main ways are tersternal long axis, doing the fractional shortening type of measurement, the Tischoltz, doing ejection fractions with Simpson's biplane, stuff like that, taking those volumes. Those are ways. In addition to that, we're also going to be measuring, typically nowadays, we're going to be measuring volumes of the left and right atria also, and the right heart. So we would be measuring all four chambers in these situations. So that's measurements. What else might we do on the echo? In 2D, before we leave 2D, so 2D and M-mode are going to be similar as far as what we do. What else would we look for in 2D? So we've got the chamber size. When chamber size gets big and ejection fraction gets bad, what do we worry about?
Regurgitation.
Okay, so we'll look at regurgitation, but that will be, so in 2D, what would you see for regurgitation?
You might see
leaflets.
sorry, Kelsey. Not coapting.
Okay, yep, so it's not coapting, so you'd see a physical not coming together, non-coaptation. You might see tenting, you might see, it's doubtful you'll see prolapse, but I mean, you could see, you'll see those coming apart, you may see them not actually touch, you may see them tenting, remember where it just touches the very, very tips. So those are clues, yes. Stretching of the, again, with dilated cardiomyopathy, is going to stretch the chordae tendineae, which don't allow the valve to shut properly. Remember, if it's a dilated cardiomyopathy, we're also just looking at the valves to see that it's not a valvular cause to it. So we're distinguishing them from other dilated cardiomyopathies. Okay, and then in color, oh, so I'm sorry, one more thing. So When we slow down the blood flow, we possibly have what? Thrombus. So in 2D, you want to look in those pockets of areas and stuff to see that there's in fact not any thrombus. So is it important, do you think, in these situations in particular, that we see the endocardium really well? Yes. So we also in 2D want to look for blood clots. Good. And because it suggested that there could be endocarditis in a native heart with native valves, typically endocarditis is going to present on the valve tips. Now, again, we'll talk about that later, but it's typically on the upstream side of the valve tip. You could also have vegetation, but again, in dilated cardiomyopathy, having that as well is more rare, but it did mention it. Good, so let's go through, and so color Doppler, obviously we're sticking color Doppler on the valves, looking for leaks in particular, hemodynamic changes in our spectral Dopplers. What kind of hemodynamic changes do you think you might see with a dilated cardiomyopathy?
Just slower?
Okay, yeah, so overall slower, which also means a smaller VTI, whether it's through LVOT, whether it's through the mitral valves, etc. And then, of course, the regurgitant stuff as well is going to be an indication of the size and function of that as well. Good. All right, so general echo findings. So 4 chambers dilated, decreased global LV systolic and diastolic function, increased volumes, increased mass index, increased LV hypertrophy or eccentric LV hypertrophy, and pericardial effusion is fairly common on this as well, but it's usually small. So we're going to be looking for pockets of fluid beyond the heart in that cardiac sac, and we have to distinguish those from pulmonary effusions. Again, we'll talk about that in the upcoming chapter. Let me go back to the mass index real quick. So what is the mass index? What is it telling us?
Was it something about how heavy the muscle is or something?
Yeah, so it's telling us the mass of the muscle tissue itself. So why do you think that, if this is a dilated cardiomyopathy, why do you think that would be any different cardiac mass than a normal LV or a normal heart? Is it stretching because of dilation?
Isn't it less mass because it's stretched out?
So at a minimum, it's the same. So it's definitely going to be stretching, but because of that stretching, remember that these are very long-term things that are happening, and you ultimately are increasing pressures overall. So there is a bit of thickening with the muscle as well. So overall, there actually is an increase in mass of the muscle itself, even though it is a dilated cardiomyopathy. We'll talk about hypertrophic cardiomyopathies in the next sections, and you'll see that those muscles are very, very thick. But there is at least a mild increase in mass index with dilated. Just to point out, because it seems a little bit counterintuitive, you'd think it would just stretch, but at a minimum, it stays the same or increases.
Yeah, and I'm looking at the next one, the eccentric hypertrophy. I feel like that would be opposite. I feel like it would be smaller. It's like with stretching and thinning.
So it's going to be trying to compensate. So you might see some eccentric. I wouldn't say that this is very common. Eccentric means that it's not equally thickened all the way around. It might just be kind of a regional area that thickens instead. So that could be part of what you see. Doesn't mean it's always going to be the case.
Would that be more related to the effects of, coronary artery disease and the opposite segment compensating?
Well, if we see that though, then we've diagnosed ischemic cardiomyopathy, and you're going to see a weakening, or generally it's going to be the whole thing is poorly functioning, and you might have some thickened segments, but they are squeezing. When we get that compensatory hypertrophy, it's because the wall opposite of it is weaker than the rest of the walls and or scarred, which would then throw it into the diagnosis of ischemic cardiomyopathy. Okay, so the eccentric thing is just because it can be there, but it wouldn't always be. But your walls are squeezing altogether, but globally they're going to act and behave the same. All right. Good. So 2D and M mode. So again, we talked about all this already, but let's just go over it and see if there's anything that we missed. So increased LV end diastolic and end systolic dimensions and volumes. Okay, so I put the picture up here, and as you can see, if you can see this very well, so here's your chamber. Do you think that's a good measurement of the LV M mode? Do you think that accurately represents the biggest volume of it?
I would say no, because you can't see, you can only see one papillary.
Well, yeah, and I think part of it is I think the other one's over here. You can sort of see it, but what I'm suggesting here is that it's not exactly in the center. Like if I was to draw a line, obviously this back wall is where they want to be, which is good, but I don't want to be here. I'd actually want to be over here, so it goes completely across that chamber, equally. So it could be slightly smaller being here than it would be if that line came from over here and through that same area. I would say that normally I'd want to come back through this area, but then you're right in the papillary muscle and you can't tell for sure. This papillary muscle is also attached to the wall, and it's probably, if they swept up closer to the mitral valve, this would be free floating, and then you'd be able to make that distinction. So this actually isn't the best measurement representation, even though it does measure big. Okay, it's not measuring as big as it actually is. So as you're doing your measurements, just be cognitive of that we're trying to get the biggest dimension that's actually perpendicular. Okay. All right, even though it does show that it's large, which we do want to show, but it's not showing it as large as it actually is. So they'll possibly have a decreased fractional shortening area and EF of the left and right ventricles. So we do fractional shortening, which is basically the space, how much does this dimension from the septal wall to the posterior wall, how much does that change? What's the fraction of that as a fractional shortening or the Tischelt? It extrapolates on that measurement in area and an ejection fraction based off that single measurement. But remember, that's the cubed measurement. That's where they assume the volume to be round, which is less accurate than doing a Simpson's biplane. Okay, so this is an indication, but it's not the best indication. Again, the spherical shape of it, you're not going to see the spherical shape in M mode, but in 2D you can. And that's just looking again at the apex. Instead of coming down and tapering nicely, it bulges out at the apex. There could be some decreased wall thickening. Again, we are stretched, even though we have more muscle technically, but it's now bigger overall because of the dimensions and the stretching that's occurring, but our muscle bulk may be bigger in the end. Spontaneous contrast. So in 2D, we could see spontaneous contrast. What should that throw up a red flag for?
Like slow flow and maybe blood clots.
Yeah, so if you're seeing a poor ejection fraction and you're seeing that rouleau effect or the smoke effect of spontaneous contrast, be looking for blood clots. And if you don't see all the wall segments well, use echo enhancing agents or a contrast. Okay. So again, thrombus, the thrombus in this case could happen anywhere because there's lots of spots along the walls that the flow has slowed down significantly, in addition to the atrial appendage.
Could you explain spontaneous contrast?
Yeah, so when you're looking at the flow come in, so we know that the flow kind of comes in, goes out, and it's usually pretty black, okay, especially on our older systems. And you may have seen this when you're doing venous exams. You'll actually see the flow coming back and forth. It looks like 2D information that's coming. It's not artifactual. You'll see it actually moving back and forth. So when the ejection fraction gets poor, you'll actually see the blood swirling with little speckles on that flow. That is the spontaneous contrast. And
okay, so I also want,
you got those stacks of red blood cells coming together causing bigger reflectors. Kelsey, go ahead.
So I'm sorry, so it's not blood clotting, it's just the slower flow, right?
Yeah, this is slow flow, but it's suggesting that you've got slow flow, which makes you concerned about blood clots.
Because I thought
precursor.
I thought the smoke effect was when you actually had a blood clot.
Well, the new systems, you can actually see it pretty well without clotting, but it does happen just before blood clots start to occur. So if you're seeing that slow flow, you should be looking for blood clots. Okay, because you have it, there's a good chance, especially if you have a decreased ejection fraction, that you might have some. But yeah, it's kind of a precursor to that, because what's happening is the blood cells are starting to stick to each other at that point, and we're seeing bigger reflective surfaces. Does that answer your question, Hannah? Good.
Yes, thank you.
Okay. Ultimately, we end up getting a shorter ejection time. So again, so the ejection time we're talking about is out the aorta. So the time that the aortic flow occurs is our ejection time. That's, remember, we add that, the total time, we add the IV-RT, IV-CT, but the ejection time is when blood's actually flowing out the aorta. That becomes shortened because it's not because we don't have big pressure and all that stuff, it's just that the ejection fraction when the heart is weak, it's not enough to keep that valve open. So we end up with a shorter amount of time. There could be mild thickening of the mitral valve. Incidentally, again, that's not something to be too concerned about. If it's thickened, it's got a disease process, and usually because we're just dealing with an older patient. But don't be thrown by that as long as the valve is functioning the way it's supposed to. All right, if we're going over the labels and stuff of the M mode of the mitral valve, you might look at a decreased D to E excursion of the mitral valve. So that's basically how much it opens. Again, it might not be as vigorous as it once was. It might not come as close to the septum, and that's because we have less pressure buildup relative to the ventricle. When the E wave opens, it's not going to open as much, and it's going to get into diastasis pretty quick. B bump, again, so B bump reveals itself. So this is an image where B bump is actually here. Now they're not seeing the posterior leaflet reflection very well in this particular view. Over here, you can see it a little bit. But what they're showing is you got your E wave, A wave, and this is a B bump here. Again, E wave, A wave, and you see that extra little bump before the valve closes. What was that an indication of? Elevated
Right heart pressures?
left heart pressures?
Left heart pressures.
I mean, technically it's elevated atrial pressure. So
I mean, the slide says RV and diastolic pressure is greater than 9. So is it RV or atria? What does your slide mean to say?
So you can have a B bump on mitral valve and tricuspid valve because they're the same functionality. We just don't really look at it that much in the tricuspid. So if you see it, so this particular note was if you see that B bump or the notch of the tricuspid valve when you're doing it, you could have end diastolic pressures above 9. So the picture is a mitral valve. That definitely has it, but what it indicates is that the atria relative to that valve that you're looking at has elevated pressures. Okay, so just know that they can look similar. It's just that we rarely, if ever, take tricuspid end modes. Even though the book notes that, I don't know of any lab that does that on that tricuspid valve. There's just other data that's better. Okay, and then obviously, because we got that big backup through everything, we do have evidence of pulmonary hypertension. What's yours, from a Doppler perspective, what's your first clue that there's elevated pulmonary hypertension?
Would it be acceleration time?
Possibly. What's the, let me rephrase that. What's the first spectral Doppler you do on your echo?
Tricuspid.
Tricuspid regurgitation. So again, the velocity of that is an indication, and you're seeing chamber. If you're seeing chamber sizes elevated, there's probably some elevation there anyway. But our first clue that something's really happening is on that tricuspid regurgitation, and that's why we measure that peak velocity of that jet. The reason we do that basically on every echo is we want to see what the pulmonary pressures are like. Okay, that's why we take the tricuspid regurgitant jet. We don't usually take that just to see how bad the jet is. We're actually looking at what the pulmonary pressures are in most cases. And then of course you add the sniff test, RVSP, adding that sniff test, right atrial pressures to that to give us that RVSP. Kelsey, go ahead.
So this is a situation where you would measure tricuspid regurgitation only in moderate and severe cases, or would you measure it with a mild trace and complete weak signal?
I would still measure. I would measure it all the time anyway. Chances are, if they truly have dilated cardiomyopathy, they probably have a lot more than just mild.
Okay, and so that's just so you can plug it in to get your RVSP.
Yes, correct. Yeah, so really it's the first Doppler we do on a standard case, and we're looking usually to determine what pulmonary pressures are like. Good. All right. All right, so spectral Doppler. So they have mitral regurgitation in nearly 100% of cases. So that stretching almost always affects mitral valve regurgitation at a minimum. Tricuspid is in over 90% of cases. I would personally say it's 100% because I think everybody has CR. That's just me. Velocity greater than 3 meters per second predicts higher mortality, greater incidence of heart failure, and more frequent hospitalization. So again, look at those TR velocities. Pulmonary regurgitation in roughly 50% of cases. Again, I think pulmonary happens on everybody. It's really a matter of if you see it. Aortic regurgitation in about 20% of cases. So that dilation of the LV can also cause aortic to regurgitate. Decreased LVOT, AV peak velocity and VTI. So overall, we got less flow going out the LVOT and aortic flow. So their peak velocities will be lower, as Kelsey mentioned earlier, and your VTI will be lower for those also. All right, same thing with the right side. So RVOT and the pulmonary acceleration time and ejection time will decrease as well. Same reasons, just less flow, a weaker heart. It's just not pushing out as much. As far as your color hue goes, or kind of the intensity of your color, it will be a dull color flow because we get those brilliant colors when we get near the aliasing velocity, which typically our color scales are set to be able to capture those normal types of velocities. They are normally close to aliasing, but when it just is very dull, we're only, and it's because our velocity overall is lower, so it's not quite coming as close to that threshold. So it might just look like a dull color compared to normal. Nancy, go ahead.
And that's everywhere with color Doppler?
Yeah, I would say that's true. So particularly through the valves, like pulmonary and aortic valves, usually that's where we start to see that more brilliant color, those brighter hues. But again, if it's very dull, that just means it flows just kind of slowly moving back and forth. Now, if you adjust your color scale, you could certainly make it look worse or better than that. So again, it's important to keep your scales relatively normal. Like if you come off of, for example, your pulmonary vein, where sometimes people will drop their color scale. Often people do that. I personally don't very often. But if they drop that down and then all of a sudden they go to the aortic valve next, it's going to alias because we didn't change our color scale back to the normal setting. So you got to be careful of those things. So opposite of that, say I had come across a hypertrophic cardiomyopathy, or I had like a Hokum situation. I know we haven't talked about this yet, but as I get into those situations, I may increase my color scale to kind of really pinpoint what's going on. and then I go and scan something else, and I need to have my color scale back down to normal, but I've got it really, really high, it may not show the normal flow state appropriately. So when you do change your color scale, just make sure that whatever you're doing to show what you're showing, you go back and change it to normal when you go to the next thing. Because otherwise it's going to hide or amplify what's going on. And that is dilated cardiomyopathy. So next time, the second section, we're going to talk more about some complications and things of it beyond that. So this is just kind of the bread and butter echo. You know, again, bread and butter, show me the chambers, show me the measurements. Okay, those are the primary things that we want to show, the actual chamber sizes and volumes, the ejection fraction. Diastolic function may still come into that as well. So you're going to want to show diastolic function things like mitral inflow, tissue Doppler, maybe pulmonary veins. You could do also propagation velocity. So those are all things that contribute to the diagnosis. Seeing the valves is kind of in between a primary and secondary, because we do need to prove that it's not a valvular cause. So we need to show the valve functions in that. I'd still kind of throw that into secondary things with it, particularly regurgitation. And then anything showing the pressure elevation and things like that. But primary, first thing that you do on a dilated cardiomyopathy, show me all the views of all 4 chambers and show their size with their measurements. That's like the main thing. And then beyond that, we're going to show the hemodynamic changes of it. Any other questions?
Scott, how does that vary from the protocol we're already doing, our standard protocol? Seems like you're still doing the same things.
Yep. My point in that is, what of those pictures is directly important information and what is irrelevant?
Well, none of it's irrelevant. It's more, isn't it more like, what is your primary, what are you primary looking at, and what are you looking at for secondary to rule out?
Yes. So in this case, because it's more of a global issue with the heart, we are going to probably show more pictures. The point is, and I think that with COVID, you may actually have situations in some hospitals where you're doing more limited exams because they don't want you in the patient room as long, because time is likelihood of infection, right? Especially if COVID's going around or other bad diseases. So they may do limited exams, and the important thing in a limited exam is that you get what you need and get out. You don't do the entire protocol, you don't do all these extra steps that take a lot of time and measurements. So the whole point of doing these pathology things is for us to evaluate your critical thinking and to see, of that protocol, what of these images are relevant to what I'm doing. Like I want you to know from a dilated cardiomyopathy standpoint, what pictures are the most meaningful in this particular pathology. Yes, we're going to look at walls, and we'll look at walls with hypertrophic cardiomyopathy as well, but we're looking at different things.
Okay, so then which views are the most important for this?
So any view that would show me a chamber, which is all of them, essentially. And I mean, there are some Dopplers that are going to be irrelevant to this. So I don't need to do like pulmonary stenosis, for example.
Yeah, so if you were called to a patient's bedside who has COVID, who needs a scan, what would you do in your 15 minutes or less?
I would get all the walls. I would do my systolic and diastolic function. And in my 2D, I'm also going to be showing the valves. So I need to know valve function. I need to know how the walls are. We're going to rule out definite ischemic cardiomyopathy versus dilated cardiomyopathy. So definitely showing the walls and measuring them and the chamber sizes.
So Scott, if you have, and this might be a stupid question, but if you're trying to get in and out of those rooms as fast as you possibly can, would you do like any measurements that you can post processing, like after you've left the room?
Yeah, and that's a great point. And a lot of labs actually do that. they'll take their pictures and then they'll do the measurements after. As a student, I don't like you to do that because I want you to know why you're getting it and to do the measurements accurately. And what you often find when you become a tech that's experienced and very, very comfortable with what you do, you know that you have good enough images. As a student, often we get the pictures that are sort of acceptable. It's like when I showed that M mode at the beginning that wasn't quite in the middle of the chamber. Some things you can't correct by manipulating it after the fact on the pack. So it's really important that you understand that you've got the best information. And sometimes when you discover that you had something or your numbers start to tell you something that's kind of borderline moderate and severe, and you need to make that determination, sometimes you need to go back and take extra pictures to make sure that you gave the best information. And if you've done that and you've already left the room or the patient has left the hospital, you either have to call the patient back, it becomes a big problem. I was talking to a tech the other day about this with pelvic ultrasounds and the way that inland imaging is doing their protocols. Their standard protocol now for pelvic for females is that they are doing transvaginal first and only if needed, instead of doing transabdominal first. Well, what happens if you thought you got all the information you needed, but you really need to go back and take another look at the transabdominal that you didn't do, and now the patient came from 3 hours away and has gone home already? Okay, so that's my point. Is I think from a student perspective, it's better to train on the fly and do your measurements on the fly and start to form that data and stuff in your head so that you know what's going on, so it doesn't make it more complicated when you miss something. Because early on, you're going to miss a lot of stuff, unfortunately, especially as a student. But even as a new tech, you're going to miss things, and you want to be on top of that. A good tech is going to know when they've got everything that they need, and they're confident that they don't need to get anything better, and they can certainly do those measurements after the fact. But I just don't personally think it's a good training to do it after the fact, because you do come across stuff that you need to redo.
Hi, Scott. Just following Nancy's question, on the opposite of that, what would you leave out of that exam? What would you not?
I mean, I'm not going to focus as much on like, I mean, if I'm going just after dilated cardiomyopathy, definitely coming out with the EF, definitely coming out with diastolic function, definitely showing all the chambers and their sizes. So all the measurements relative to that. I don't necessarily need to spend a lot of time on the size of the pulmonary insufficiency or looking for pulmonary stenosis and doing acceleration times and, you know, things like that aren't going to be as relevant. I mean, if that's needed for something else, I can always come back and do that later if they want to.
In each lab, they'll have their like formulated protocol for COVID patients too. Also, you've got full on PPE, so.
Yeah, I mean, I think the scare is certainly less now, so you might not see this. So in most cases, you are going to do a full protocol. But as I was talking to Tammy yesterday, it's often harder to do a limited exam than it is just to put your brain in neutral mode and just go with it, doing your regular protocol. So when you have to think about what's relevant, this one's a little bit more of a general process, and so is hypertrophic cardiomyopathy. But some things like certain valvular diseases, or if you're looking for a certain congenital process or connection issue, it might be a lot more specific to what you're looking for. So some things are going to be more specific, some things are like this are going to be general. Now, does our general protocol cover absolutely everything you'll always need to do? No. There's going to be times that you have to do measurements beyond the standard protocol. For example, if you've got a VSD, our standard protocol doesn't do everything you need to do for a VSD. You have to add some additional measurements and stuff on top of that. And that's where you break out this book. And you're like, when I go in the room, what do I need to get? I break this book out and I look it up. Yeah, it's the protocols are meant as a minimum basic that covers most things, probably a good 90% of what you're going to see. There are going to be that 10% of times where you have to kind of modify what you do or add to it. So I always look at the protocol as a minimum standard for a whole exam. If I'm doing a limited exam, then I just need to pick out the pieces that are directly relevant to what I need to see. And sometimes the doctor will tell you, it's like, I want this. When you go to an ER, or you're looking at a lot of your hospital patients, they order a full echo, but all the provider wants to know is what's the ejection fraction. So they can get that, and they'll often be coming to bug you to find out what it is, even though it's not our job to tell them. But that's often what they want to know before they release a patient from the hospital, for example. But you would never just give them that only, and that's it. I would do at least a little bit more than that. How do you think that links to billing? Can you just make an adjustment on the fly and say, oh, I think they need a full echo versus a limited echo? What do you think?
I bet you they're paying for a full echo no matter what.
Nope, not necessarily. So one of the most important things, and I hate that this is the case, but it is, and that is that the echo tech or ultrasound tech, generally speaking, when you do a study, one of the first most important things that you need to do as a tech is make sure that the billing code is set correctly. Otherwise, you could get rejected from being paid. So you need to make sure that the exam is appropriate. So there's actually what's called an appropriateness criteria. I believe at the back of Feggenbaum, there's actually a whole chapter on appropriateness criteria, and that's stating, from a billing perspective, when they give you a billing code, it has to be linked to certain information, and if that doesn't match, you may not get paid for it. The clinic that I used to work in, and I haven't seen any other clinics do this, but we actually used to have the billing department come down on, like our quarterly meetings, and they would talk to us about what kinds of studies were being rejected. Because you think of doing, if you did 10 studies in a week that didn't get paid for, that's a good 10 hours of scanning time that machine was used up on a patient that didn't get paid for. That's 10 hours of tech time. That's additional hours of interpretation time that all didn't get paid for. Okay, that's not good. So you get too much of that, and it's obviously the clinic's not going to be very strong. It's not going to be financially stable. And in the end, if you do that too much, guess who loses their job? Okay. So even though we may have done an awesome echo, if it didn't meet the billing standard and what needed to be done, that could come back to bite you. So I hate to say that we're, kind of a policing of billing reasons, but we are. And what we do as techs is it's important that when we get an exam ordered for a certain reason, to verify that reason is actually valid. In other words, that if they've been diagnosed with something, we need to have something that shows that they've been diagnosed with it. It needs to come from the doctor or the provider or whatever. They can't just, they can't order an exam, for example, for rule out dilated cardiomyopathy. They have to give me a reason as to why they thought they had dilated cardiomyopathy, which goes back to the clinical history, which goes back to their previous diagnoses of other exams. We need to have a reason that they suspect that. They can't just have a suspicion and order an exam for no reason. For example, if they thought that they had blood clots in the heart, they need to give us a reason why they thought there was blood clots, like they have AFib. That's a good reason. If they have a low ejection fraction, that's a good reason. If they had a history of TIAs, that's a good reason. But just doing it just because is not a good enough reason, and it might actually get rejected. In fact, I had one clinical site that was doing a certain thing that they thought that Inland wanted, and Inland didn't back them up on it, and that site ended up getting fined like $150,000 over a 7-year period because they inappropriately did that exam. So it can come back to have real repercussions. So as an echo tech, just make sure that when you're doing an exam that you have good verifiable information for your clinical reason for doing the exam, along with the proper billing codes. So with the billing codes, that often builds in if you're doing Doppler, if you're doing 2D, if you're doing strain imaging will actually have a separate code. 3D 4D imaging has a separate code. Those are things that need to be put in appropriately. If you bill for it and there wasn't an order for it, you can get fined.
So Scott, what would you do as a tech if you notice that there's not sufficient evidence to order a study? Who would you go talk to? The doctor?
Then you contact the ordering provider. So you could talk to your cardiologist if there's something that you're really on the edge with and you can't get any other answers. You could ask them, and they can actually validate that sometimes. Cardiologists typically can't order their own studies. Well, not entirely. They can't get paid for the tech side of it. There's complications there because they can't. If they were allowed to just do what they wanted to, they would have free reign to bill whatever they want to, and they could just make stuff up if they wanted to. That's the philosophy. So to prevent that, cardiologists really can't just willy-nilly order stuff. Same thing with a radiologist. But the best thing to do would be to contact the provider's office and have them verify and make sure that we've got a good reason. Or if they just said that they thought they had blood clots or to rule out blood clots, we need to know why. So if they told us then verbally that they had TIAs or they had this or they had that, or they had a previous low ejection fraction and stuff like that, then those are good reasons and we can use that. But the appropriate thing to do is to contact the provider and make sure that they give us a better reason.
So even if they give it to you verbally though, would they have to provide that with like documentation?
They really should, but they can give it to us verbally.
Okay.
So back when I was scanning, we didn't have as like the Epic system, for example, it's out there, the EMR system. They now have so much stuff built into that it's, and the provider actually is the one that's supposed to go in and put the order in. When I was working in Deaconess, for example, though, it was common for the ER docs to say, you know what, order me a DVT study and, order me a DVT study. And they tell the MA at the front desk, and the MA doesn't really know what's going on. So the MA orders an arterial exam for DVT. Well, that's a completely inappropriate diagnosis for what that is, for the exam type. But that's what often happened, is that the doctor would tell somebody else to put the order in. That person didn't know what they should be putting in, and so they put the wrong thing. I had one of my colleagues once got so upset at the ER, like, these doctors are idiots. They don't know what they're doing, blah, blah, blah. And I'm like, just to put it out there, I said, I bet you if you talk to the doctor, they know what they ordered. And if you call them, they would tell you that. I said, I guarantee what happened is that they relayed that piece of information to somebody else to put in the system, and they did it, which isn't really how they should do it. And it ended up getting the wrong order. He actually tested that theory out one day, and they ordered something like that. It's like a DVT. They ordered like a bilateral upper and lower extremity arterial and venous exam for DVT. Well, that's totally inappropriate. He called the doctor himself, and the doctor's like, no, that's not what I wanted. I want this. Like, oh, that's what I thought. So sometimes it's the communication in that department when they put those orders in, it gets mixed up. And it's most appropriate that the provider is the one that actually puts in their order because they know what's appropriate. Other medical staff aren't trained to know what's appropriate for certain studies. So in the end, you contact the provider, whether that's the ER, whether that's if you're in a clinic, that could be an outside provider at another clinic somewhere. It could be like a nurse practitioner, a PA, a doctor of some kind that's ordering this stuff. And sometimes they just don't know enough about what they're actually ordering. And you might need to educate them to say, I need the order to say this. If you're doing a study that doesn't have Doppler built into it and they order just a 2D exam, but you need Doppler information, it's important that you have the order state that it's for Doppler as well. Otherwise, you're not going to get paid for it. And you really can't diagnose it these days without having Doppler. That makes sense?
Oh, yeah.
Sorry, I just made your job more complicated. But in reality, if you get good at understanding the billing, because you also, when you bill your study out, you actually put in the codes for it. And it's kind of our job to filter that and make sure it's right. And then it goes to the billing department and then they put it in. And when you have a billing code, those ICD-910 codes that they're out there, that code actually states in its documentation that when you bill for that code, you need to get this, this, and this. If you didn't get all those things, then you didn't do the study appropriately. So I hate to say that we got to become billing experts, but in a sense, you kind of do. You'll be a better tech for it, we'll say that. And billing gets complicated, but if you need help from your billing department, if you got questions about that, ask your billing department. They are the experts in what the codes are, what they say. They could look up exactly what's needed, that type of thing. So when we build protocols, for example, at Inland, we build that in conjunction with the ICD-10 codes. We actually go in and see what's required to be obtained in that set of images. And that's sometimes why the protocols have what they have in it. That's my soapbox for the day. Any other questions?
I don't know. It just seems to me like it would be hard for a physician to determine why they got dilated cardiomyopathy. Like, say, for example, this patient had pre-existing, I don't know, like MR or, yeah, or MS. I feel like it would be hard to say, oh, this is definitely dilated cardiomyopathy and they got it from this.
That's true. And so we do what we can as an echo tech. We'll show that there's not other valvular disease going on, that there's not other processes, that they don't have regional segments that have scarring or things like that. So that's our job to prove that. If they get to that point and they still question what's happening, can they make dilated cardiomyopathy decision on our echo alone? No. What do you think they could use to help determine that more particularly?
Just everything we just discussed, like the systolic function, the ejection fraction, the wall appearances, the myocardial index.
So that goes back to our echo. But if you really needed to diagnose something, what would you do in addition to the echo? So if the issue on dilated cardiomyopathy is a fundamental muscular issue, and say we're thinking it could be sarcoidosis, it could be global triple vessel disease that's just not revealing itself. It could be something else. How could they distinguish those aside from echo? Think of our 136 class.
Are we talking just like try medical management first or like biopsies?
So that's how those
MRA.
Biopsies would work. MRA would work. MRI. So MRI is very good at characterizing fatty versus other types of muscular tissue, stuff like that. So they can actually do some of those. The biopsies can actually determine if there's like amyloidosis or sarcoidosis or some infiltrative disease process. So there are other testing that they would do to determine those things. So yeah, if they came out of the echo, they didn't have enough answers and they really wanted to have a diagnosis. That's why we have all of our other imaging modality options and even lab testing and pathology samples and stuff like that. Yes. Yeah, we can't do 100% of everything off of echo alone. We do have to work with, we're good at what we are. We're awesome. We're the best imaging of all, but we still need to have MRI and these other guys with us too. Right? Okay. Now we're good. We just have to know our boundaries and respect the boundaries of others because they do provide useful information and we do provide useful information, just different pieces of information. And that is the world of echo. Good. All right. You guys have a super awesome day. We'll discuss the second half of this tomorrow.
Thank you.
Thank you. Thank you.
Good day.